Good afternoon. My name is Karl Hazel. I'm a consultant gastroenterologist in Connolly Hospital, Blanchardstown, with a special interest in inflammatory bowel disease. And the focus of this episode today is IBD and the importance of preventative, life-changing treatments that allow patients to live a full life despite this chronic condition.
Hi, my name is Loughlin Campion. I am a patient. I was diagnosed with ulcerative colitis 6 years ago now, and thankfully I've reached a state of remission and happy to share my story about the experience I went through with the disease and dealing with it.
So Loughlin, could you tell me a little bit about your IBD diagnosis and your journey with the disease at the start, I suppose?
Yeah, I was diagnosed with ulcerative colitis 6 years ago. I had no understanding of the disease initially, but had a few tough years dealing with the disease, but thankfully I've reached a state of remission and my health has been very good the last 3 or 4 years.
Great.
So very grateful for that.
And at the start, did you find there were any delays, I suppose, because obviously you're a young man? Did you delay in going to the GP about your symptoms, or was there a delay in getting you access to care?
I probably did delay a little bit. I needed maybe a little bit of encouragement to go because it's the symptoms that you'd get initially getting diagnosed with inflammatory bowel disease are not kind of ones you'd speak about.
Yeah.
So I thought it was, I'd experienced symptoms of diarrhea. I was like, this will be fine after a few days. And then when it's not fine after a few days, you have to take action. So I must say, I think the initial weeks from symptoms to getting a scope and diagnosis, it was quite good. It was quite smooth, I must say.
Okay.
Yeah.
So you found there was no real delay?
In my experience, there was no delay. I know plenty of patients may experience delay, but in my experience, it was a quick turnaround of a few weeks, yeah.
And how did it impact your life at the start? Were you out of work or?
Yeah, huge impact initially. Even getting to grips, I didn't understand what I was being faced with initially. I had no experience of ulcerative colitis. I didn't know anybody who had ulcerative colitis or Crohn's disease. So I had to just figure it out. And yeah, I had to adapt my diet, change my lifestyle, lived a very active lifestyle before my diagnosis, had to kind of temper ambitions with what I wanted to do that year. And all of a sudden, even simple things like socializing, something that should be enjoyable, like going out for a meal with friends, going for a few drinks, was complicated and became more stressful, to be honest. And there were times I had to take time off work. I worked as a primary school teacher, active job, you're on your feet. And I managed it as best I could, but didn't manage it so well. But got through it.
And how were the supports, I suppose, at the start? Did you find that you were well supported? I suppose you gained access to medical care quickly, it sounds. But I suppose the supports around that from a dealing with colitis perspective or having someone to talk to, how did you find that?
Yeah, I probably looked around online for Facebook groups and things like that of other people who were in the same boat. Like I said, I was over and back to the pharmacy. They got to know me very well. Great support there in terms of getting the medication I needed. But I suppose you're just looking for somebody to relate to or a relatable story. And it's difficult to find, people who are talking about Crohn's disease or ulcerative colitis. And I came across the Crohn's Colitis Ireland podcast when I was in hospital, and that definitely helped, just because they break it down into little sections about different parts of the experience, and that was good to hear. That was great support, yeah.
And how did you, I suppose, how long was it from diagnosis to you ending up in hospital? Had you been well for a period of time, or how did that go? When I was initially diagnosed, the consultant told me I had proctitis, which is inflammation of the lower colon, but the nature of the disease is that it can spread, and I suppose over time it was spreading, and I had become so used to the urgency and the frequency of
going to the bathroom, that looking back now, I think I just kind of accepted that was my lifestyle, and that reluctance to live the lifestyle I had been living before diagnosis. I almost kind of, I just took a step back from everything. So without realizing it, I developed this new lifestyle, which was honestly, if it can be summed up, it was just spending a lot of time at home. Yeah. And even though, yes, I'd love to go traveling or out for a meal, I just didn't want the hassle or the stress of dealing with it. Yeah. So yeah, it was tough.
I think that's definitely something, I suppose, in my experience, that, Crohn's patients or ulcerative colitis patients, they kind of fall into this normal for them pattern, which could be 7-8 bowel motions a day, outside, looking for where's the nearest toilet, can I go there, is there a toilet, things like that. And it just, I suppose, becomes their normal, but it's not necessarily normal for someone that doesn't have Crohn's or colitis. So would you agree with that kind of side of things?
That's exactly it. Yeah, it's not normal. And I think my disease, I feel like I had a kind of my initial diagnosis was, I felt like, okay, I've the colitis that's not so bad, you know, because they showed me the chart and the different levels of inflammation, and they're like, you have this one. I'm like, okay. And I just, I was a good patient and I took my medication, but I didn't appreciate that it was slowly getting worse. And then it was also kind of the height of COVID, and in 2020, hospitals weren't necessarily places where people wanted to be. Yeah. So it was only speaking with an IBD nurse at hospital, they said, no, you need to, it sounds like you need to be admitted. And that's what finally sorted me,
And with proctitis, did you feel that, did you ever come across, I suppose, times where people said it was just proctitis or underplayed your symptoms because you had just proctitis?
So I think that the first year of my diagnosis, that was the year I thought, okay, it's not too bad. Yeah. And this will get better after a few weeks or a few months, and I'll just take the medication and the medication will work, because that was my understanding of illness, right? So I hadn't experienced chronic disease, and the clue's in the name, chronic, so it's going to go on for a long time. And I just didn't appreciate that first year. And when symptoms didn't start to improve, my mental health probably took a nosedive, frankly. And I was thinking, okay, this is just me. I was thinking, I'm taking the medication. My colitis is apparently not so bad, so I can't get on stronger medication. But it was only when I went in for another scope that, I remember a doctor saying to me, okay, this, you could be looking at surgery was an option at that stage, and that was just, the disease was able to kind of, worsen over a period of maybe 18 months. And
do you think us as a group of gastroenterologists or IBD doctors, for somebody who's diagnosed with proctitis, do you think we could be more vigilant, or maybe, I think there is a predisposition to downplay proctitis a little bit, but your symptoms are the same. It can get worse, like you said. Do you think when we diagnose you with proctitis, we should be, I suppose, not in inverted commas, just say it's just proctitis? Like I said, do you think we should take it more seriously, maybe?
I mean, I think the gastroenterologists I've met have always taken my health very seriously, but I think it's more so an understanding that this is a disease that can spread and worsen, and the experience of a patient with chronic disease is almost, there's a certain acceptance of your situation, because like I said, for your own head, you need to kind of accept that you're in a tough health situation with your health. And also keeping a little bit of, and hope, and kind of just having something in your life that's going to, get you up out of bed. And even for me, I was a big runner before I got diagnosed. I pretty much stopped running completely when I was diagnosed. But then all of a sudden, I kind of just started cycling, which was, it's like running on two wheels, so same thing. It's more expensive. So that helped me a lot. Yeah.
And was there anybody, I suppose, in particular during your course at the start, was there anybody that stuck out that helped you through it from even medical perspective or from friends, family? Was there one person that helped you get through it more, or?
The nursing team in the hospital I thought were brilliant, honestly, because they were always there to call. I had the number, and just any queries about my meds or, you know, my symptoms, they were there. Like I said, I think that just initially I was just maybe not willing to call because I didn't think it was too bad. And I thought there were patients who were worse than me, and I didn't want to waste anyone's time, which is silly looking back, but maybe that was my mentality. But family, friends, they were just of huge support, you know, particularly my family.
Okay. And then obviously you were admitted to hospital and I presume started on a medication. Mm-hmm. And how's your life been since, or how did things change for you after you were started on infusions?
Yeah, so that was July 2020. I had my first infusion, and I think even the inflammation tests they used to take then were through the roof. And over the course of, I'd say, close to a year, symptoms started to improve. But even those initial months of infusions, I was thinking, it actually just shows the level of inflammation that that doctor mentioned to me, where surgery, you know, just don't rule it out, because we're going to try this drug and hopefully it works. And it did work. Infusions helped me, and that's it. I'm in remission now the last 3 or 4 years, thank God. But yeah, the first few months, I think it's just, think of chronic disease. It's, for some, it's slow to be diagnosed, and it also can be slow to improve, and slow to settle, and slow to reach a state of remission. But just shows you there is hope there, you know?
Absolutely. And your last check-in, then you're in full remission?
Full remission, I'd say. I think it's always in the back of your mind. You always have to be conscious of it. So I am immunocompromised, shall we say. Mm-hmm. But I keep that in mind. If I ever feel quite tired, I take rest very seriously, which is important. I don't do stress. Stress is not good. You know, didn't do stress before I was diagnosed, but I definitely don't do it anymore.
Do it now. Yeah. Okay. And is that a big thing?
Yeah, huge.
Even though you're on treatment?
Definitely, yeah. I think you just get to know your body very well over, like, with a long-term disease like IBD. And yeah, fatigue is there always. I think it's just about absorption of, you know, nutrients in the food you're intaking and your system. And then you realize, I mean, I've met other patients in hospital. Patients speak to each other, and I've met people who are in remission, and that's the reality of the disease. Like, you're not necessarily guaranteed, you know, a clean run for the rest of your life. So it's always there. Yeah. So even just that understanding that I have of it now, it's a much better understanding of that first year where I didn't really know what I was facing.
I think we're getting a little bit better at understanding as well that fatigue is a huge part of IBD.
Yeah.
You know, there's kind of big studies coming from Newcastle and things where they're looking at patients' lives and fatigue scores and things. And even for patients who are in remission, you don't necessarily get rid of the fatigue. So it's something that, as a IBD-ologist, we have to keep in, or I suppose in consideration, that fatigue is always, or could potentially always be, part of your day-to-day life. But I know you mentioned earlier that you're living in Spain and Australia. Do you think that would have been possible 5 years ago, or do you think you would have even thought about that 5 years ago?
No, definitely not. It's funny, like, I think to my friends, I'm quite an active person. And that was probably the toughest part of my diagnosis. The first year was when all of a sudden, you know, I just wasn't at training and things like that. And people were saying, where were you? And I think initially I was making up excuses that I was injured and stuff like that. So I think I took a career break from teaching a few years ago. And my goal was to go traveling, you know, because when you're sitting inside an infusion room in a hospital, you're looking out at, you know, you're just looking at people doing things that you can't do. And the thing is, I'm not saying I didn't travel when the disease was active. I remember going through security in the airport with all my meds and things like that. But I just was maybe reluctant to, you know, I just wouldn't go off on a big long trip, or I wouldn't I'd stay close to home, or it was short haul flights, shall we say?
I suppose you're always the worry: is it travelers? Is it something you picked up traveling, or is it the colitis rumbling in the background? Or
but I didn't want to. I think some of my friends, they might think, oh, he's gone off to Australia to train full time, and there's maybe an element of truth in that. But the reality is I didn't see Australia or living abroad as an option for me for maybe a good 4 or 5 years of my life. So then when you reach a state of remission, you're thinking, okay, what haven't I done? It's just, you have this huge new lease of life and ambition,
Yeah. So you mentioned training, Loughlin. What
Here we go.
What is training, or what are you training for?
Good God knows. Yeah. Training for life. I don't know. I've always been training on some level. Like, even yesterday I was doing the national Olympic triathlon, finished in the top 5. So
congratulations.
That's huge. So even just something like that, I felt that every level of training and competing was complicated, and my whole the whole reason I liked training years ago was just the rush of endorphins, the social aspect, just being outside in nature. The disease, I was like, okay, now going for a run is stressful. I always feel underfueled. I'm exhausted before I start running. So I'm going to deplete myself further. And for what? I can't meet up with my friends to train because what if I have some urgency? And even I remember that first year when I was trying to figure out how could I run, I was like, okay, maybe I could just, instead of running 5Ks or 10Ks, I'll be a sprinter, and I'd go up to the track, and then there's always a bathroom there. But that didn't work. I remember 1 or 2 people might ask me to go for a run, and I was too, proud maybe to say, oh no, I can't. So I just wouldn't eat anything the evening before meeting them. And I'd get up early, I'd set an alarm for 5 a.m. and I'd just go to the bathroom all morning, and then I'd meet them at 9 a.m. for a run. I'd go out cycling with my friends. We'd stop at a cafe. Everyone would have a coffee and a scone, and I just would sip on a bottle of water, totally depleted. And the thing is, deep down, I knew that was unsustainable, So I was thinking, all right, this part of my life is over, So it was very tough. Yeah, very tough.
And since treatment, you're back to it, where you've gone from running to triathlons.
That's
right?
it. Yeah, I had to do something. So it just shows you the cycling is such an accessible sport. It really is, So cycling, I was like, okay, at least I can do this, and I'm outdoors. And yes, I can't. I remember I used to get to about 2 hours, and that was like my limit, and I'd start to get quite tired then, Yeah. So, but 2 hours is a good cycle, Yeah. And then just I have this competitive thing in my head where I just wanted to try a bike race, and I actually did okay, I won a race even my first year I started racing, and that was the other thing. Training for me is all about progression, Yeah. You're trying to reach the next level. Runners want to run faster, people in the gym want to lift heavier,
Yeah.
That's the way it is. And I felt around that time I had gained a better understanding of the disease, and I thought, okay, I'm depleted. I don't think this is something that I can progress at because I'm already struggling. I was finishing these races and I was getting dizzy sometimes afterwards. I was falling asleep driving home. So I kind of knew the writing was on the wall. I thought this is not an option for me. And then thankfully that experience coincided with the infusions. And all of a sudden the year after that, I was just a new man. I had just boundless energy. I started doing much better than I expected in these races. Racing the national championships with professional cyclists. Rode the Ross Charlton around Ireland, held my own, didn't win, didn't come last, but I did all right. And then I promised myself if I reached a state of remission, I'd try to get the running going again. Okay. And so that what led me to triathlon, probably what gets me up out of bed early in the morning to go swimming, something I might have not have done years ago, but just the experience with chronic disease is enough to shake you up to realize you got to make the most of your life,
So if you met somebody, I suppose, that's just at the start of their journey in a similar situation, what would you say to them? Would you say this is what can happen, or would you give them hope, I suppose, that you can be symptom free and back to...
Yeah, definitely. I think it's different for everyone. I feel like if there was a graph, I think for me, it was just, I had this deep dive from, they're like, the diagnosis conversation was, you have proctitis, and I was like, okay, it's not too bad. And then it really got worse and worse and worse. And it was a long journey out of it. Like, I didn't think it was going to improve. I think that was the toughest part. It was kind of the hopelessness of it all. And I just thought, this is not improving here. And then, it did improve. So I just think maybe even people listening to me would be thinking, okay, maybe it wasn't that bad. Like, he's like, listen, I won't bore people with the details, but like, it's not a nice experience. And it's day to day, it's every day, So even if you might have a good day, I never slept through the night, I'd always have to get up to use the bathroom. So even that, you always have a broken sleep, And if I slept through the night at breakfast, I'm thinking, hey, I slept through the night. This is brilliant. I had a great sleep. Just little things like that. Even if you have a good day and you're thinking, I only went to the bathroom 4 times today, 5 times. Yeah. The next day you'll go to the bathroom 10 or 12 times. And then you're thinking, okay, you're going back through, all right, what did I eat yesterday? And then it's almost like you're putting blame back on yourself. You're like, I shouldn't have eaten that. I couldn't resist whatever it was. I mean, I didn't eat green vegetables for 3 or 4 years. I didn't eat grains, porridge, any of that stuff.
Because you're told no heavy food or no.
Exactly. And it's just always on your mind. And just even the fatigue with that, you're like, will it ever just give me a rest here? So could you please tell us a little bit about IBD as a disease?
Inflammatory bowel disease, as I was saying, it's an umbrella term for 3 conditions, really: Crohn's disease, ulcerative colitis, and indeterminate colitis. So ulcerative colitis affects the large bowel only, but can present in Loughlin's case, proctitis, but then can extend to left-sided colitis or a pancolitis. And Crohn's disease tends to affect the small bowel and the large bowel, but can affect you anywhere in the gastrointestinal tract. Symptoms, I suppose, are traditionally diarrhea, fatigue, bleeding, weight loss, failure to gain weight. And what I suppose in my experience have seen, there's sometimes a delay in getting a diagnosis because people downplay their symptoms, or diarrhea becomes a normal part of your day-to-day life. So maybe instead of being diagnosed quickly, you're 6 months further down the road. But once you have access to care, things, you tend to get a colonoscopy. We have non-invasive ways of diagnosing IBD, like fecal calprotectin, or aids in our diagnosis. And we now have intestinal ultrasound services across a good few hospitals in Ireland where we actually scan the large bowel and see, or the small bowel, and see, is there inflammation there? So that's something we're trying to roll out more across the country. Even since, I suppose, I've started my training or completed my training in gastroenterology, we have a lot more medications than we would have at the start. We have simple medications like steroids to try and get you into remission. And then for ulcerative colitis, you have medications that kind of take inflammation out of the bowel. And then you have advanced therapies like infusions or pens like you're taking. But I think the key, I suppose, is early diagnosis, early treatment, and a push for more advanced therapies early, if possible, if your symptoms aren't settling down. But I think you're right, Loughlin, it's a chronic condition, and we always aim to have you kind of linked in with a consultant for life, and with the kind of broader team like the IBD nurse, if possible. So they're your real point of care, point of contact, if you're having a flare, because the quicker we treat it, the better we keep you and the quicker you get back to your day-to-day life.
So what would be the key advancements that's been made in diagnosis and treatment of IBD patients?
So I suppose there's an expansion of the services across the country. There's more, I suppose, IBD physicians employed now that have an interest in IBD, which kind of steers the service a little bit more towards recognising patients that may have IBD and getting them linked in quicker, whether it's for endoscopy or not. I think non-invasive things like fecal calprotectin tests, which you may be familiar with.
Yeah, I am.
To not only, I suppose, diagnose or help with diagnosis, but to, I suppose, monitor as well. So, or, if you're not feeling right, we get you to do a fecal calprotectin. We see it's on the rise and we can intervene early to stop you going into a full flare or needing hospitalization. And I think the big thing at the moment is intestinal ultrasound, like I touched on earlier. It's a non-invasive marker. We get to bring you to clinic. I know for my own service, I use it, I suppose, as a rapid access clinic for patients who might have a flare of IBD. So you have quick access to IBD care. So we get you in, we scan you, we see that there's inflammation, and allows us to either get you started on something extra to take the inflammation down, or pushes you more towards, getting in quickly for colonoscopy to make sure that we are treating you right, I suppose. It also allows us to see, I suppose, response to therapy without having to do colonoscopies. But I think we probably will still, colonoscopy is still required because mucosal healing is a big part of treatment in IBD to ensure that everything is healing. And we know there's large kind of systematic review meta-analysis this year that shows that if you have mucosal healing, your outcomes from all aspects, whether it's clinical symptoms, your kind of fatigue scores and persistence of treatment are all much better if we do strive for this mucosal healing and full endoscopic remission.
So are there any issues in monitoring the disease for the average Irish patient?
Yeah, I think as I touched on before, I suppose ready access to the services. I suppose the clinics are booked up and getting patients in every few months to see how they're doing. And that's where I suppose the IBD nurses or A&P led clinics come into play, that I suppose they can follow up patients a little bit more closely. I think fecal calprotectin is always a difficult one to get done, but that is, I suppose, the non-invasive method of following them up. And then obviously there's a push with colonoscopies and outpatient urgent colonoscopies that maybe IBD surveillance is put a little bit on the back foot. So it's kind of access to endoscopy, access to outpatients definitely reduces how often we can monitor our patients or access for patients to us.
Very good. I forgot to ask you what led you to specialise in IBD.
That's a really good question.
Because I'm a big fan of gastroenterologists, so.
So I always wanted to do gastroenterology. I really liked the interventional side of things, that you can do endoscopy as well as be a really good physician in the background. I did a science degree before I did medicine. I did biochemistry. So it was very heavily based in immunology. And at the time, I really didn't like immunology, but over time, I've developed an interest in it. And that's why I liked IBD, because it's not just the endoscopic side of things. It's thinking about medications, pathways. I actually really like dealing with kind of seeing people getting better quickly when we do start you on treatment. And also, I suppose, that little bit more of a holistic care, that it's not just the Crohn's or the colitis, it's how you get better, as cheesy as all this sounds, and watching you kind of improve, get better and get back to a normal life, but also, I suppose, having that little bit of extra interest that we kind of watch you a little bit more or see how you go. And I had two really good mentors through my years on the scheme that were very IBD centric, and I just really looked up to them. And I thought, that's who I want to be like
Sure.
and work with.
Can I ask, when the disease is active, like I'm now probably in remission for about as long as I was very sick. So it's kind of equal. What is going on with the disease? What's happening in the body, and the medication or therapies that, what's going on to improve it? Does that?
Yeah. So
is that a fair question?
Yeah, I think so. Yeah.
In layman's terms.
So I suppose if you're on infusions or the pens, I suppose IBD is, I always say to patients, IBD is your body's overreaction to the lining of your bowel wall. I suppose it's whether that's completely the right way to say it, but I think it's the easiest way for people to understand it. So there's lots of inflammatory molecules around, and the infusions or the medications that you take, I suppose, knock out those molecules, whether it's at a very high level or whether it's at a low level, and just switches off that inflammation and that overreaction to the bowel wall. We don't really know what has caused that switch to turn on, whether it's a change in your natural bugs in your bowel. That's kind of a preponderance of the bad bacteria. We know there's possibly environmental factors, because in countries that are, in inverted commas, westernizing, IBD is becoming more common. So whether it's a shift in the types of food we're eating as a group, not a specific type of food, or something in the Western diet or the Western environment that turns it on. Genetics play a very small role, particularly in Crohn's disease. It's very small. So I don't know if that answers the question.
Yeah, I didn't know that about the genetics. It's a small role, is it?
Yeah, it's more environmental, or I suppose the clear genetic role is quite small. But whether there are genes that get switched on because of environmental factors, if that makes sense.
I was 28 when I was diagnosed. Would that be a kind of a typical, or what's the window for?
Yeah, so there's two peaks, I suppose, kind of late teens, early 20s into your 30s is the first. And then there's a later peak, kind of early 60s up to 70 even. So it kind of dips down. We don't know why, whether it's maybe steroid levels in the body. We don't know that they dip at 2 points after adolescence. I'm not sure. Okay. But there are two peaks of diagnosis. Yeah, so late teens, 20s, and then into your kind of 60s.
So would you have any advice for patients who are not seeing improvement in their symptoms?
So I suppose that's the key area, that is communication with your IBD team, whether that's kind of your first protocol is the IBD nurse or whether it's your consultant. That I suppose you do need to give the medications time to work. And my worry always with IBD patients is that if we don't get a quick response, sometimes we move on a little bit too quickly, and we have more medications now than we did, but we don't have an endless number. So it's kind of linking in and really teasing out what your symptoms are, and is it something else that's going on, or is it the Crohn's or colitis that's been active, and is there room to, I suppose, use more drug or optimize that drug, and then okay, fair enough, if it's not working, then we move on to the next medication. But always, I suppose, involving the patient in the decision, not just saying you're going on this drug, here you go, and always talking about the pros and cons, because we're at the point now where you don't just have one drug as your option. You have a few drugs that you can use, particularly when you're moving on to your second line. So it's kind of what works for you and works for the patient. And that was something I learned when I was in the UK in my fellowship. The patients chose their drugs. The doctors steered, but because they had, I suppose, free reign over what they could use, the patients really chose, I want this drug because I think that works better for my lifestyle or things. But it's always, I suppose, being steered by a physician, but based in evidence of why that's the right drug or not the right drug for you at the time.
Yeah, you mentioned ultrasound and its importance earlier.
Yeah.
Could you tell me more about the importance of training? And
Yeah.
with ultrasound machines, where the responsibility for that lies?
Yeah. So it's part of every gastroenterologist training in Germany and Italy. So they've always used it as a modality for everything, I suppose. It's not just IBD, but it's part of their training. So there's the International Bowel Ultrasound Group, which was set up, and their goal was to roll it out across Europe and the world. And it's available in Australia now as well, and Asia. And how that works, I suppose, is you go to do a training session, usually somewhere in Europe, but we have had one in Ireland now, for 2 days of intensive, I suppose, ultrasound training. And ideally, you have access, and to a point, you have to have access to an ultrasound machine before they will sign you up for that. So that's where it's important that we've more centres in Ireland if we want more people trained in it, because it has been shown to reduce costs from an MRI, colonoscopy, outpatient perspective of up to $500,000 a year.
Okay, very good. And what are your hopes for the future of patients with IBD, or how do you see things in the next 10 or 15 years?
Well, I think, like I said, even since I've started working, we see you in hospital less than we would have before. We use a lot less steroid.
That's been my experience.
Yeah, less steroid, the better. But I suppose to have IBD as an outpatient disease or group of diseases, but also I suppose to get it recognised from a patient perspective that it is a chronic disease, that you tend to be in the younger side of things when you're diagnosed. You're out of work. Your ability to carry out a normal life if you're unwell, isn't as good, and that we kind of get that recognised and classed kind of in the chronic disease category. But also, I suppose, more of a free rein in the medications that we're allowed to use, because it's not one group or I suppose it's not one disease for every patient. Every patient is a little bit different and will react to medications differently. So if we were allowed to use, I suppose, the armament that we have, because we have a lot more now, to really tailor it to our patients. And I think maybe in 10 years' time, we might find that one target to treat, and it'll be a patient-tailored treatment. That would always be the goal, that if we can find in each patient what their target is, we can treat that.
So preventative healthcare as opposed to kind of reacting.
Yeah. And I think things like ultrasound, like I said, if we have any hint or that you're flaring, we can bring you in, but also I can bring you in, say, at a more regular basis than I can for a colonoscopy, because that's where we've limited resources from that perspective. Yeah. We can bring you in, and we know that ultrasound, I suppose, shows changes before necessarily your symptoms do as well. So we can prevent things, we can make changes when we see the changes and stop you ending up in hospital or unwell.
What would you say to policymakers?
So I think
making these decisions.
So I think overall we need more funding towards IBD. So we had a push towards more IBD nurses, which are always the patient's point of contact. We're now not getting any more. That's what we have is what we have, even though the rates are growing all of the time. The patients on our books are growing all of the time. But we work with the same resources with more patients. So I think that's something that needs to be recognised, that, and I know that every doctor that you would talk to will always say that their specialty needs more, but that is also the nature of healthcare, is that we do need more. And that would be my one push, would be more resources, both inside and outside the hospital, access to dietitians for our patients with IBD, which we don't necessarily have. So more allied healthcare for our patients, more consultants and more ultrasound machines, and roll that out as part of the national training programme for trainees who want to do IBD. So Loughlin, what are your hopes for the future for IBD?
For IBD, that patients get the treatment that they require and that they deserve, and that nobody has to experience that anxiety and uncertainty around the disease that I experienced. So I think a better understanding of it overall,
And do you think, just something that's coming to my head as well, do you think access to things like clinical psychologists for IBD would be important?
Definitely. Yeah, definitely. That would have been so beneficial, even if just hospital visits, if they mentioned that there was a support available, and just someone to talk to about it. Because I just felt I was caught or trapped a little bit, because I was thinking, okay, I have this diagnosis, this is the rest of my life now. And when you experience a few weeks or months or even years with the same symptoms, it's logical to think, okay, this is my state of being now. It's not improving, but just goes to show you it can improve. So I just, even listening to you speak about other patients and treatments, I just feel very lucky. Like I just, even my own future, I just feel really lucky. I just feel like I've gotten a second chance, and why would you, there's people walking around there and walking around every day in their picture of health, and understandably, they don't understand what it feels like to lose that. And I do know what that feels like. So I'm making the most of my health now, and it's great. So it's just the little things. Yeah.
Thank you for listening to the Innovate for Life series. If you found this episode interesting, please share and look out for other episodes in the series of Life Because of New Medicines.